Good morning, teammates from Exercise Science 4700. I'm Dr. B, and my teammate here is Nate. Nate, hold there for just a second if you would. The objective of our video today is to make a record of the range of motion, active and passive, neurologic exam, and special tests of the hip and pelvis. So we're going to start out with active range of motion. First of all, unlike the shoulder where we had an official name for it, aptly scratch test, as you recall, these don't have an official name. We're just going to do functional tests. So Nate, I've already assessed his fluidity of movement other than the range of motion. Active range of motion, Nate, would you please come over here and face the camera like we always do when we're safe. Back up so your knees are touching the chair. You are. Good. And I'm just going to have you put your hands across your chest so it's all glutes and hips and knees and quads. Would you please sit down? And we're looking for the motion there, of course, active range of motion. And stand up again, please. Good. Well done. That's all we're going to use for the chair. This was mostly for, it was an eccentric sit and a concentric stand of the glutes. I'm going to remove the chair. And no, we're not ready for the bench yet. If you would, just right here, facing me. If you would now, please, bring your right knee up to your chest, and you can help it with your hands as much as you'd like. Your other right knee. Ha! I got you finally. Where he's corrected me appropriately a number of times. Well, I used to teach dance, so we're always looking for the chance to say no, the other right leg. There you go, thank you. I don't hold you for range of motion, but typically about 135 degrees here of active range of motion. Go back to standing, please, and let's see the other leg. So here we are targeting hip flexion and down. We have done active hip extension. Now, if you would please, stand with your feet as far apart as you can, be comfortable. That's great. Average at least 45 degrees, but he could go further. Again, if you're a dancer, you'll go out to 180 degrees. I've never attempted that on purpose. And bring your legs back together again. Now, if you take one step forward with your right leg and cross in front of your left leg. Active range of motion, right hip adduction, A44. Step back. Let's do left hip adduction, A44, right there. That's about 20 degrees typically, so he's doing well. We do have some trunk rotation, but it's necessary when he moves that far. Step back to neutral, please. So we've done extension and flexion, abduction, adduction, and would you please turn your toes in? And so we're doing hip bilateral internal rotation. Isn't that an interesting thing, how we are wired? When you do this, your upper extremities do it too. And you did that normally. But just an interesting thing. There is science behind that, but we won't go there. So, internal rotation, bilateral, and you can get about 45 degrees. Now, feet together and toe out, if you would, please. Let's see if he's got his fifth position, ballerina. Better than usual, way beyond normal, which is, he's at about, doesn't matter, but we usually do about 45 degrees out, and he's out to about 90 degrees with each foot. And relax, comfortable position, good. These are the active range of motion in standing weight-bearing position, which is important because most pathologies will present, most all will present when you're weight-bearing, but not all will present when you're non-weight-bearing. Okay? But we're still now going to do some active range of motion in the seated position. So I'm going to slide the chair over. If you would please go ahead and sit down. Would you please cross your right thigh over your left thigh? There you go. Actually, if you can, slide it on over. There we go. We're after adduction, A44, and external rotation. It appears to be, yeah, it's still external rotation. He could force it and try some internal, but this is adduction A44 and external rotation. Non-weight bearing AROM. If you would do the same thing with the opposite leg, please. External rotation and adduction of the hip. Back to neutral, if you would. Sitting tall in the chair, thank you. Now, if you take the outside of this foot and rest it on the top of your knee. This is hip flexion, external rotation, and abduction A24. Thank you, sartorius. We also get the knee flexion is contributed to by the sartorius. We talked about that with soft tissues on the previous video. Go back to neutral and with the other foot, please. There you go. Thank you. And he's got his, within reason, full range of motion there. And back to neutral. Would you please now, let's have you go to the table. If you'd stand up. We're now going to go to passive range of motion. There are a number of ways to do the same thing. Would you please lay on your back and be comfortable? Thank you. Actually, I'm going to have you stand up. Let's move this out. I didn't consider me going behind the mat. Okay, go ahead and lay down now. We're going to do each of the range of motion again, but this will be passive range of motion. I will be doing it for the client. There are a number of ways to do it, and I'll represent a couple of them for each of the ranges of motion. Keep in mind that when we're doing passive range of motion tests, if you just add resistance, it turns it into a manual muscle test. So I will speak to it, but I won't necessarily demonstrate it. And I will speak to the nerve root innervation. Did I say it right? Invention, whatever it is. Innervation. Thank you very much. We need to make these films a lot more professional. But anyway, that's not who I am. I will do passive range of motion to him. I will report the nerve roots of the motions, and that we can do this also for the manual muscle test. At this point, Hoppenfield starts with hip flexion, and he goes right to a pathology hip flexion contracture. Your iliopsoas or your sartorius or your rectus femoris, the primary hip flexors, may be in contracture, an irregular, relatively permanent shortening of a soft tissue. That being the case, he won't be able to fully lay the leg out when I do certain things to his pelvis to neutralize it. Usually 90% of the time, if you do have a hip flexion contracture, it is because of the iliopsoas. Okay? So we're going to start with, I'm going to slip the back of my hand underneath his lumbar spine. Laying in this position, the lower dotted curve of the spine is exaggerated. And if you stay here very long, your back will actually complain to you. For this reason, just a little side note, if you are a supine sleeper, always put a couple of pillows or bolster under these legs. This is why your professional masseuse, massage therapist, when you're laying down on your back, they have a bolster under here. If you're a belly sleeper, we need to put the pillows, the bolster under the pelvis in order to put the pelvis in a pelvic neutral position. ASIS, PSIS, all neutral. In this position, he's likely got an anterior tilt. And in time, the supportive structures in the small of the back will become agitated and it becomes painful. So we won't stay here very long. I'm going to slide my knuckles underneath the small of his back so that I can feel his spinous process on my knuckles. What I'm going to do is listen with this hand as I bring this knee up into flexion, this hip into flexion. His pelvis will roll back into neutral, and I'll note at what point his pelvis is pinned against, or his lumbar vertebrae against my hand. Now I'm going to keep track of that, because as soon as it comes off, it means that it tells me a number of different things, and I'll explain those later. Now I'm going to grab your leg. We already have permission to touch before we started the film. And if I do anything that makes you uncomfortable, you let me know, all right? So passive range of motion here, this is Thomas' test for hip flexion contracture. It is also a passive range of motion test for hip flexion. That's why I'm going here. So Hoppenfield refers to it as a passive range of motion test, and at the end of the chapter, it's also a special test for hip flexion contracture. I'm going to bring your knee, I'm listening with my left hand for his spine to bind down and become fixed on my knuckles, and I'm taking this up to his there. Now his pelvis can't rotate anymore, it's fixed, and would you please hold on to that leg right there. While doing that, I'm looking at this leg, because if he's got a hip flexion contracture in here, and the pelvis has come back a bit but then fixed, this leg will come off the table to a degree. Okay? That's the positive sign. Now I'm going to take this leg up and have you take a hold of it. Now please return this leg back down. If he's got a hip flexion contracture, it will stop at about that position. Okay? And also now we're going to drop this one down. And I had looked at it before, so that he does not have that condition because he's able to drop them both down to horizontal. So passive range of motion, hip flexion. I'm going to go through some other motions. Let me have you roll over on your left side, please. We can do abduction, A24. Slide back towards me so that my mechanics are good and I don't hurt my back. Straighten this leg out. We're going to bend this leg in order to shorten the length of the lever. And with me controlling the leg, thank you, stabilize the pelvis, and I'm going to take him into pure abduction, A24, and back down. There's a special test we do that I would normally do right here, but I'm going to teach the sequence of Hoppenfield. So we have a normal, stabilize the pelvis. It's purely glenohumeral, no, acetabulofemoral. He'd have caught me on that anyway, of abduction A24. While he's here, I'm going to move this leg here and do a sideline adduction A44 of the other leg up to here. We do get soft tissue obstruction, but there's not much adduction to take place anyway. Does it make a difference if we flex the knee? Not much, because we're still into adduct soft tissue obstruction. I'm going to have you, I would then have him turn to his other side and do the same thing, abduction A24 with this leg and adduction with this leg. And roll onto your belly, please. And now I'm going to do PROM of hip extension. Again, we want to shorten this right here. And I will stabilize the pelvis by laying my arm across the iliac crest and the PSIS. And I will lift his leg by the ankle, or you can do it down here, and just take him up into extension. That's about all the motion. After this, I'm starting to get trunk rotation and other things taking place. So truly, that's normal, and we're okay there with the PROM. And I, of course, would test it bilaterally, and I can do that with the film in this position. Let me have you on your back again, please. Another method to do adduction and abduction, and actually it's my preference. If I did not get any resistance with the manual muscle test here, I would then, meaning I did not have a 4 out of 5 at least. Given gravity isn't involved here, but I can tell if he's got the strength to overcome gravity. If I sensed he couldn't overcome gravity, I would do the sideline abduction and adduction up against gravity to see if we've got a 3 or less. But I prefer this right here. I'm going to have him, please. You're relaxed, and I'm going to slide his legs out to abduction and back in. And I can instantly go to adduction and adduction. Hoppenfield actually teaches to stabilize here and do it yourself from here. Personally, I've worked with too many 350-pound offensive linemen whose right leg weigh as much as I do, and my back doesn't tolerate it. So I have all the power right here. I can do abduction adduction. Turn it into a manual muscle test. Please do that same movement and push out against my hands. Good. Now, again coming back. Push, 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 and relax. Good. In this position, I also am ready to do hip internal and external rotation. I can control the ankles. From this side view, once again, look at my biomechanics. My back hurts a little bit today, to be honest. And as soon as I go down here, my pelvis goes into pelvic neutral. It takes that stress off, and it's all arms here. And that's not tough with him because he's not a 350, 400 pound offensive lineman who bench presses 400 pounds. So I can take him out a little bit, and we're going to reference the kneecap, starting vertical, neutral, like a vertical axis, and I can turn them in and turn them out. And this is normal range of motion. And your manual muscle test is resisting here or here. For hip flexion, you can do it in the seated position and just have them reach up and touch your hand. Or here I can do it by stabilizing here to have the best resistance. Go ahead and bring your knee up to your chest, and I can resist this way. Hold it right there, hold, 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 and relax. Hoppenfield points out that hip flexion is innervated by L1, 2, 3. Hip flexion, 1, 2, L1, 2, 3. Okay? Then we're going to move the leg out and adduction in sequence. A4, 4 is L2, 3, 4. Flexion is 1, 2, 3. Adduction, 2, 3, 4. So back to here. Abduction, A2, 4 is L5. So we have 1, 2, 3, 2, 3, 4, 5, and on his belly, hip extension is S1. Make a note, a mental note, that in our documentation, in fact, when I was preparing for the video today, I noted in my margin over there, oh, hip flexion, L1, 2, 3. It's a check mark. When we're documenting, rather than write flexion often, we will just put a check mark, which means flexion. The mark without the check means extension in our therapeutic documentation. Check is flexion, so in my margin I have flexion, hip, L1, 2, 3. Then I had just a backslash. Extension, hip, S1. Okay? So 1, 2, 3, 2, 3, 4, 5, and hip extension is S1. This is two ways we can check the passive range of motion, with him here and me working up here controlling the limbs, or me controlling the limbs down here. And another way, also important, because things can change if the person is seated or supine. I'll have you slide down to the end of the table and drop your legs off the end, please. Again, it's easy enough. Slide back so your knees are touching the table. There you go. Thank you, and relax. So test these same tests both in supine, reclined, or sitting up, because hip flexors can be involved, or pelvic stabilizers, and it does affect the motion we get in the hip. Very simple here, and I actually prefer this one over supine with me controlling the legs. I'm here. Remember, I don't want to be bending over with my biomechanics. I'm going to get at eye level, and I can do the hip flexion, have him bring your knee up and touch my hand. That is harder to do, and relax. And we can do the other one. And we've already done extension. Now I can do passive internal rotation, even though the feet are going laterally, and internal rotation. I can resist them with a manual muscle test. External is L5. No, the abduction and adduction is. So I can do internal and external rotation here very well, and the adduction and abduction I can do from here and here. The hip flexion I can do from here, And then the extension, when he stands up, I'll see he's got AROM, so I won't need to test PROM. These are the active and passive range of motion. This is also the strength component of neuro exam we covered. Again, by repetition, hip flexion L1, 2, 3, hip adduction A4, is L2, 3, 4, hip abduction L5, hip extension S1. So we've done the motor. The sensation is, and you already know this, but we'll review it, from the umbilicus, which is T10, immediately superior to the inguinal ligament is T12. So between the two is T11. On an oblique angle, paralleling the inguinal ligament, immediately inferior is L1. Then we have above the knee, and I jumped down for a reason, the inferior border of the L3 pattern, again, parallels the inguinal ligament, an oblique pattern above the patella and into the medial knee. So 1 is here, 2 is here, no, 3 is here, so 2 is going to parallel it right here into the medial thigh. Crossing the patella is L4 down the medial calf. Crossing just below the patella and lateral to the shin and vertical to the dorsum of the foot is L5. And then shadowing the peroneals or the lateral calf and the lateral foot is S1. Okay? And relax. Do take a look in Hop and Fill. They talk about a rectal exam. We're not going to do it in this class, but the purpose of the rectal exam is you can enter, the physician can enter through the anus and supinate the hand and actually mobilize the coccyx bone and palpate the sacrococcygeal joint and actually mobilize that joint. It may be fractured there posteriorly when a woman gives birth because of the child coming through the birth canal. They can place it back, but it's supposed to be a synarthrodial joint. Or if it can be fractured and pushed into the bowels, the large bowels, from an accident of landing hard on your butt, and the physician can mobilize that. Also from the anus, the physician, and this is what's typically done, is the physician can palpate the prostate gland of the male through the anus by entering and then palpating anteriorly. They can feel the texture, ooh, we've heard that before with palpation, and the size. And that is often a more effective test than even the blood draw. My GP actually relies on that more than the blood draw, but he uses both of them. So that's what Hoppenfield talks about there. Now we have done neuro and range of motion. Let's go to special tests. One of them is for hip flexion contracture, and that was the Thomas test that we've already demonstrated. Make note in Hoppenfield that if you do notice that when one leg's up and the other leg is suspended in the air and they're completely relaxed, gravity can't even take it down, that iliopsoas hip flexor is tight. Okay? Now, 3 different things can happen that tell you they've got a hip flexion contracture. One is that this doesn't drop all the way down. Another one is the upper body starts to rock forward because they're limited to here, but the leg might be real heavy relative to the body, and it can pull the whole pelvis forward. And another thing that will indicate positive for a hip flexion contracture is if when you're here and they try to drop the leg when I've got one to the chest, if you would hold that please, and this one drops down, but it can only go here, but it wants to go all the way because of gravity and a heavy leg, it will continue to go, but the pelvis and the lumbar spine will come up off of my hand. So the whole pelvis had to rock again because it's like, do I move the femur on the pelvis or the pelvis on the femur? Open kinetic chain versus closed kinetic chain. So make note of those three can indicate a positive hip flexion contracture. More special tests is Obersign. This is a tight iliotibial band. If you would slide up your head to the face pocket, please, on your back. There you go. And now over on your left side, but come towards me. Again, there's an example. I don't want to get my center of gravity forward. I want it over my base of support. Let the client come to me. And sometimes we'll do things where they're almost off the table, so it's my body here is giving them the security. Back a little bit further, please. There you go. Good. Obersign is for iliotibial band syndrome. High repetition of high energy knee extension, running hills, running stairs. The iliotibial band, and I noticed earlier, pick your leg up if you would. This is actually his iliotibial band right here. He has a great specimen of an iliotibial band. There's another test we'll do that'll make it stand out better when we do the knee. But the tensor fascia lata, somewhat a hip flexor, ties into the iliotibial band, crosses over the greater trochanter, may get to rubbing back and forth on the trochanteric bursa. There we have snapping hip and potentially trochanteric bursitis. But this band can get kind of become inflamed and even contracture. So, it's a wrestling match whether you argue if the tensor fascia lata and iliotibial band is an abductor or not. I'm not going to do that. You can argue that, debate it, discuss it in your kinesiology class. However, if that band is tight, we're going to straighten this leg. I'm going to lower my center of gravity and control this leg. Stabilize the pelvis. The Ober test is about relaxing the leg, making sure I've got it, and then I get to a certain position and let it drop. If we have a contracture or a condition of the iliotibial band, then it will clunk about right, not necessarily clunk, but stop before it has soft tissue obstruction. The iliotibial band can be so tight, it'll suspend the leg here. Now, a lot of different techniques with this. Hoppenfield teaches to do it right here. As a PT, I'm trained to do it at almost 90 degrees of hip flexion. They feel with the research that that makes it more of an abductor or abduction stabilizer. As an athletic trainer, I was taught really mobilize the hip, get them loose, and then split the difference and go ahead and drop it. I'm not letting him just roll over. I am dropping it and stabilizing that pelvis. That is Ober's test or Obersign for a tight iliotibial band. Another test we're going to do on your back, please. Your other back. Please lay supine. He's a professional. He wants the real terms. He's just making me feel better. Come down this way a little bit for the sake of the video, but keep your calves on the table. There you go. Okay, we have true leg length discrepancy and apparent leg length discrepancy. True leg length discrepancy indicates that there's a difference between one femur and the other, or one tibia and the other, the weight-bearing bones in the lower extremities. We're going to identify the ASIS, and again with your skills, don't just go to the ASIS, that's this. Go to a spot on the ASIS. I'm going to step just off, and there's my landmark. With the soft cloth tape, we're going to start there and use centimeters in these measurements because you have more increments to refer to. And I'm going to take it all the way down to a spot on the medial malleolus. I presume you can see that from the A spot on the ASIS to A spot on the medial malleolus. I step just off the most prominent spot, and there I have a measurement, okay, of this leg. Now bring the other leg over. Doesn't matter that I'm coming from this side because I'm still using the same leg landmarks, and I will check this side again for bilateral symmetry. If I have a discrepancy, we can distinguish if it is femur Or if it's tibia, I'll have you bring this leg up to here and bring this other leg up as well. Have them even here. Now, if it's femur, this femur bone is going to project anterior. So I can look and then one leg will be out this way more than another one. If this one's out further, it tells me that the difference is in the femur. If the knee sits higher, I'll put a book on the knees, and if the knee sits higher, that tells me the problem is between the tibias. It hasn't told me which one's which, but we would know that from the true leg length discrepancy test. So we can measure if there's a discrepancy, is it tibia or femur, and then the femur will project out this way, the tibial tuberosity of the knee will be forward, and if it's tibia, the knee will sit higher. And if we were here in person in the class, we'd find several of you with that very situation. You'd be surprised. I'm going to do something here real briefly, and no, once again, he's a fine specimen. You'll find a lot of people don't even have hip or back problems, but if you'll bring the legs together like this, the malleoli will be 1 centimeter or 2 offset from each other. So something you can do, this is a little therapeutic, you get them relaxed a little bit, hold on to the shorter one and get them relaxed, and then you just give it a quick jerk. And then you measure them again, and they're symmetric. And it wasn't painful, they weren't in pain in the first place. I digress. Ober's sign. We have true leg length discrepancy, now apparent leg length discrepancy. This is indicated by, we have a discrepancy, it appears, but it's not in the bones. It's not a true discrepancy. It's a matter of the positioning of the pelvis. If here's our true pelvis, ASIS, PSIS, if we have an obliquity, one leg is longer than another. If we have a hip flexion contracture, one leg is shortened because it's gone into flexion at the knee and the hip. So an obliquity or a hip flexion contracture or adduction of the hip of one lower extremity will present with a leg length discrepancy. How we're going to measure it this time is from the umbilicus. Locate the umbilicus, and now I've taken the relationship of the tibia to femur to ossa coxa out. I've just got a length from the umbilicus, and I'm going to go to the inferior aspect of the medial malleolus and then pivot right back over to the other malleolus to see if there's a problem. If there is, it's one of those 3 things: an obliquity, a hip flexion contracture, or an adduction of one of the hips. So that is true versus apparent leg length discrepancy. In Hoppenfield, do take a look. Another thing that may happen is internal or external rotation of the hip. So we have a natural, when we're born, the head of the humerus is cartilaginous and there's not an acetabulum. This is embryology. It is weight bearing that causes that acetabulum to form and the neck to go into slight flexion and anteversion. So it goes slightly, posterior, anterior. Anyway, there's so much of that is normal. Hoppenfield speaks of looking down the line of the leg. I personally really struggle with that. I don't rely on it. And I don't use this test much. So I will refer you to the reading, but you can see that the leg, somebody might be walking down the hallway and toeing in on one leg and not the other, or bilaterally, or toeing out. It may be that their foot is pronated or supinated. It may be a torsion in the tibia, more common than you would think. It may be a torsion, a twisting of the bone because of congenital or genetic in the femur. Or it might be tight hip internal or external rotators, or it might be a condition of the femoral neck is anteverted or retroverted. It's more than the 15 degrees it's supposed to be. It's supposed to look like this. My young clients in the school district, that were never weight bearing because they didn't have the motor strength, we would strap them down in the table comfortably and then crank it, and it brings them to standing so they can be weight bearing. We want gravity pulling through the skeleton to make that acetabulum form, and the neck of the femur, did I say humerus before? Neck of the femur form its proper angle. A slight flexion and 15 degrees greater trochanter anterior, I believe it is. I won't hold you for that. But if they're never weight bearing, I've seen the x-rays of a 21-year-old whose head of the femur is just like this on the femur, and it's sitting up underneath the iliac crest of the ilium because the hip socket never formed. So we're going to help them form that by strapping them down and making gravity form that acetabulum. Another test, dealing with a youngster. I don't have an infant model here, but in hop and field it refers to ortolani click. You've got the little youngster on their back and you're pumping their legs and playing with them. They're small enough you can wrap the heel of your hand around their knees and then take these digits 3 and 4 in behind the head of the femur, femoral head, and as I externally rotate and slightly abduct, I can take that head and it will click and dislocate. Not painful to the child. They've got a lot of open space there and nothing's very well formed yet. But if it's congenitally, because it was present at birth, dislocates, that's the ortolani click. You can take that leg and dislocate those little acetabulofemoral. Another test we do for congenital dislocate is telescoping. I've got the child here. I can bring the leg to 90 degrees of hip flexion and knee flexion, and controlling the entire limb with one leg, I can pull it up, put tension on it, and push it down. And by telescoping back and forth, I can sublux or dislocate that hip if there is an existing pathology. And finally, there's the abduction test, which to see if their abductors are tight. A child should be able to go out, hip flexion, abduction, and external rotation quite a ways. But if it's tight, it's basically the same thing as the ortolani click. You're just going to force an external rotation and an abduction A2-4 and see if you can even get it there. If you can't, then we have a abduction contracture with the youngster. One more important test is the Trendelenburg sign. Let me have you please step down and let's move this table out of sight, out of the way. All right, in sports medicine we talked about gluteus medius weakness or lateral lurch or gluteus medius lurch. In stance phase, my abductors are doing an isometric contraction, preventing my pelvis. My center of gravity is not over my base of support. I'm going to collapse. Healthy gluteus medius and minimus do an isometric and keep the pelvis level for that split second before the next foot gets down. If it's weak, every time I stance phase, I will collapse. We don't like to collapse as humans, so I will throw my center of gravity over the weak side, over the base of support. You'll see somebody who walks like this. Right unilateral gluteus medius weakness or lateral lurch. Left unilateral, or you've seen bilateral gluteus medius weakness, okay? To test for that, to confirm it, if I could have you stand here facing that way. When this gluteus medius is contracting, it will lift the pelvis slightly this way. Please do hip abduction of this leg. Correct, and relax. Open kinetic chain. movement in the frontal plane around an anterior-posterior axis of the femur moving on the ilium, the os coxa. Now, please stand on this leg and do hip abduction. Okay, then relax. Actually, I would have you do slightly this. I should have coached you ahead of time to exaggerate it. This time it's close kinetic chain, and the ossa coxa is moving on the femur, but it's still movement away from anatomic position in the frontal plane around an anterior-posterior axis. Femur on pelvis or pelvis on femur. That's what happens in stance phase. If it's weak, it can't do it. May I have permission to roll your shirt up and drop the top of your trunks down a little bit? No, actually we can see them. There's the dimples, and I'm right on, and I confirm with listening with my fingers, and you agree, does it feel like I'm on the same place each side? PSIS, level with S2. What I'm going to do, normal, is when he stands on one side, in this case the left, don't do anything right now, this right PSIS should lift up ever so slightly, because it's going to do a close kinetic chain hip abduction and do this. If it's weak, these will stay level or it will drop. That is positive Trendelenburg sign for gluteus medius weakness on the weight-bearing side. Let me have you stand up, please. I'm sorry, pick your right leg up. There you go. See how much higher I am here? Normal. Relax. Let's have you stand on your right leg, please. Pick the left foot up, and there he goes again. So it's me I'm not biasing myself. Those PSIX are actually going up. No, the non-weight-bearing side is going up because of the close kinetic chain, hip abduction on the involved side. Go ahead and turn around, face the front. This is the active range of motion and passive range of motion. Neuro, we did sensory and motor strength. There are no reflexes in the hip. And then we did special tests for the hip, and also for the youngsters that you can do. And this is the assessment according to Hoppenfield. Thanks for your time.